Hello, Blazers. Welcome to episode 148 of UAB Green and Told. Original release Monday, April 21st, 2025. Through this podcast, we're able to share stories from members of the UAB community. Want to check out past episodes of UAB's most downloaded podcast? Visit alumni.uab.edu/greenandtold, Spotify, or the Apple Podcast app. And while there, leave a written review so more alums can find us. I'm Greg Berry, a UAB alum and Director of Communications in the Office of Alumni Affairs. Today, we welcome Dr. Benjamin Hippen, a renowned physician whose career is marked by dedication and a passion for medicine. As intelligent as they are, many doctors may find certain specialties daunting. But for Dr. Hippen, it was actually the complexity of nephrology that proved to be a compelling challenge that led him to Birmingham.
Physicians who are not nephrologists really perceive nephrology as extraordinarily complicated and difficult, and certainly aspects of it are. But I think that allure, candidly, also had an appeal.
Celebrated for its remarkable role in renal research, Dr. Hippen knew UAB was a beacon of hope for countless patients and respected its pioneering practices in kidney transplantation.
In part because of its storied reputation as a near founding kidney transplant program in the United States. The history dates back to the late 1960s.
And as he'll share, he authored an extensive 25,000-word document as he reflected on his practice and realized the depth of his oversight.
I found myself embarrassed by a particular dilemma. I didn't know where any of my patients in the dialysis facility, where I was a rounding attending physician and medical director, where any of my patients were in the transplant evaluation process.
As a child, Benjamin Hippen led a somewhat nomadic life. After serving in Vietnam, his dad took a job with Mobil Oil, which meant the family relocated every 3 to 5 years. They lived in places like Pittsburgh, Philly, Motown, and Northern Virginia, where Benjamin attended high school. This on-the-move lifestyle exposed him to diverse cultures and communities, broadening his horizons and shaping his worldview. Yet amidst the chaos and change, one thing remained constant: his dedicated dream to become a doctor.
I knew from a fairly young age that I wanted to be a physician for reasons not much more complicated than my academic interests were biology and English, and I was looking for an opportunity to unify those two interests, and medicine seemed like the obvious choice.
As a part of your educational career, at what point did you get drawn towards the career path that you wound up taking? Was that during undergrad? Was that at Baylor? Or was that when you were looking at residencies and fellowships?
My path back to medicine, I think that's the most accurate way to put it, was a winding one. I started off as a biochemistry major, and I took an undergraduate course in philosophy, a 101 ethics course, by a professor named Larry Temkin. He introduced me to a series of texts that really hooked me on philosophy. I entertained a double major in biochemistry and philosophy, and finally realized that what I was really interested in was philosophy. And so I dropped the biochemistry major, completed all of my pre-med requirements for the sciences and math and everything else, and devoted my undergraduate years to philosophy. It also opened a door for me that proved to be very important. I spent my junior year abroad, which allowed me to attend Trinity College, Cambridge in the UK, which was a wonderful experience, a transformative experience for me. I entertained a career in philosophy. I applied for and was accepted to a PhD program in philosophy, and my intention was actually to pursue an MD and a PhD in philosophy. One of my mentors had done the same more than a generation ago, and was a scholar in the philosophy of medicine, the medical humanities, and medical ethics. And that was the initial career path I had in mind for myself. But after I started medical school, and in particular after I got some direct clinical experience, I realized that what I really wanted to do was practice medicine, that a lot of the topics that I was interested in philosophy, I would get considerably more, as it were, practical experience as a clinician.
Where did the interest in nephrology come from? Because that's what wound up bringing you here to Birmingham.
I knew I was interested in internal medicine
Okay.
and not surgery. And I was interested in internal medicine because it seemed to me the most akin to philosophy.
Okay.
There's a lot of very smart people, a lot of complex problems. There's sort of features of dynamic problem solving and a commitment to managing a number of complex comorbidities all at once. All those things appealed to me. At Baylor, the physicians who seemed to not only know quite a lot about their subspecialty, as you'd expect, but quite a lot about internal medicine, that is, who were very skilled internists, were nephrologists.
Okay.
So at our various academic meetings, whether it was morning report or various grand rounds, it was my experience that the nephrologists seemed to know quite a lot, not just about their own subspecialty, but about internal medicine generally. And that was what initially attracted me to nephrology, was the idea that perhaps someday I could also be a superlative internist as well as a subspecialist. There are a number of particular medical problems that attract nephrologists. It also has this allure, I think. Physicians who are not nephrologists really perceive nephrology as extraordinarily complicated and difficult, and certainly aspects of it are. But I think that allure, candidly, also had an appeal. Transplant came along later.
Yeah.
So I'm both a general and transplant nephrologist, and the reason that I ended up at UAB was primarily to pursue a career in transplant nephrology. The thing that was especially interesting to me intellectually was that patients who are on immunosuppression, medicines to chronically suppress their immune system so that their immune system doesn't reject their organ, have an altered natural history of disease. So a disease that may commonly present in a certain way in an immune competent individual sometimes has a completely different presentation, a completely different natural history when someone's on immunosuppression. So it was almost like learning traditional internal medicine and then learning an entire subspecialty or subcategory of internal medicine altered by chronic immunosuppression.
In your career, in your academic career, you've been very deliberate in selecting the colleges, the universities that you would attend. What was it about UAB and its program that drew you to Birmingham?
A significant component of my interest in transplant nephrology was the opportunity to make use of my interest in and training in philosophy. My mentor at Baylor College of Medicine, a gentleman named Dr. Wadi Suki, who was counseling me on where to look around for nephrology and transplant fellowship training, strongly recommended that I attend UAB, in part because of its storied reputation as a near founding kidney transplant program in the United States. The history dates back to the late 1960s, pioneering work by Dr. Gil Dehelm, who was a transplant surgeon at UAB, who really built the program. UAB also had a number of long-standing and tenured faculty who had decades of experience in transplant nephrology. And there were faculty there that Wadi thought would overlap with my interests in the medical humanities. And he was right.
Did you know going in that philosophy would be so instrumental in your career?
No, I certainly wasn't planning to study philosophy as an undergraduate. But once I was bit by the bug, as it were, it was hard to imagine not integrating it substantially into my professional interests. UAB was very encouraging of this.
What was the program like when you were here?
It was a wonderful place to learn. Nephrology division takes care of a wide array of patients with kidney disease. It has a talented and dedicated group of faculty who I benefited from tremendously. The work was hard, but I would say it was well worth it by virtue of the clinical exposure to a variety of different types of kidney disease that we received, as well as the didactic education that we received. It's a very science-heavy training program where fellows were expected to attend grand rounds, didactic lectures. So it was a well-rounded curriculum. The longstanding tenure of many of the faculty members allowed us to benefit from the long experience of individuals who had seen the evolution of nephrology over many years.
You've made a career in nephrology. You've done everything that you can do with kidney disease. Nephrology can be sometimes overlooked by medical students. Why is that, and how can we encourage them to go down that path?
That's a wonderful question, Greg. I've thought about that question a lot, in part because I've had such a wonderful career in nephrology. I'd say my answer to this has actually shifted over time. When I applied for a fellowship position in nephrology, it was quite competitive. It was as interesting to young and talented internal medicine graduates as cardiology and gastroenterology are today. In the last decade or so, the appeal of nephrology has fallen off a lot. Nephrology fellowship programs around the United States now have vacancy rates of 30 or 40%.
Wow.
It often competes with geriatrics as among the least favored medicine subspecialties. I think the reasons for this is in part because the career of a general nephrologist in private practice can be quite difficult. The patients who we care for are sick. They have multiple medical problems and are quite complex to manage. They disproportionately also suffer from the wrong side of the social determinants of health. In addition, there are new career opportunities for recently graduated internal medicine residents that are more conducive to a more fixed schedule with fewer encumbrances that are inherent in running a private practice, like running a business, which physicians typically have almost no training in. For physicians who are less interested in the operations or the business of medicine, a job like a hospitalist can be quite appealing. The hours are fixed. You're employed by a hospital system typically, or a hospitalist group that manages the operations and negotiates contracts and the like. And it provides a fair amount of personal liberty because the work is primarily shift work. So for those interested in a different balance between work and life, that can be quite appealing. The compensation is attractive and in some cases superior to folks who are just coming out and practicing nephrology. And it just appeals to a different set of preferences. I do think that there's opportunities to make nephrology more appealing along these lines without losing what, in my and other nephrologists' view, makes nephrology such a joy. I think there's still an opportunity to attract those engaged and high-performing internal medicine residents, but also provide them career opportunities that allow them to maintain more of a work-life balance than was historically prioritized by the previous generation. And I think that's quite reasonable, a reasonable ask on their part, while also exploring and advancing the field in myriad ways. And I mean, my own career is an example of that. When I left UAB to join a community practice in Charlotte, I was not sure I was going to stay in a community practice. I'd still sort of harbored some interest in an academic career. And so I started writing and publishing. Now, my area is bioethics and public policy. I don't need a lab or a grant or protected time. And I was fortunate to have partners in practice who were quite happy to let me pursue my own academic interests, so long as I took care of my patients well and did my job appropriately. That was an easy overlap for me, but it afforded me the opportunity to pursue a side academic career, as well as participation in professional societies and regulatory bodies that were completely compatible with my professional practice, while also pursuing the academic interests that I'd always harbored and remain committed to.
You have transitioned into the role of Global Head of Clinical Affairs, Global Medical Officer, Chief Medical Officer at Fresenius Medical Care. What are you doing in that role? And it seems like it's an undaunting task just because the title is so long itself.
Yes. So it might make more sense if I backed up a click and explain how I ended up at Fresenius.
Sure. Yeah.
So about a decade ago, I was in full-time practice in Charlotte, practicing both transplant and general nephrology. And I found myself embarrassed by a particular dilemma. I didn't know where any of my patients in the dialysis facility where I was a rounding attending physician and medical director, where any of my patients were in the transplant evaluation process. It was particularly embarrassing to me because I played such a large role in our kidney transplant program. If I didn't know, it was certain that my colleagues in my practice also didn't know where any of their patients were in the transplant evaluation process. And that became an odyssey of self-education on how not just the political economy of kidney transplant worked, but sort of the same sort of questions around general nephrology and dialysis. Okay. And that culminated in an exercise that I often engage in when I am faced with problems that I find vexing or troubling. I write. So I ended up writing a 25,000-word, unpublishable because of the length, white paper that was, as much as anything else, an exercise for myself in trying to understand how all these different parts and pieces of the system worked. But it was done in an effort to try and sort through how the system could be changed on a system level to make this work better for patients and families and physicians and systems. I had met my current boss, Dr. Frank Maddox, who is currently the Global Chief Medical Officer for Fresenius Medical Care, a conference. And sometime later, unsolicited, I sent him that manuscript. Not sure what the response would be, having sent that along unsolicited. But about a week later, he emailed me back. He'd read it and was interested in discussing it further. So he invited me up to Boston, and that became an on-again, off-again collaboration over a course of years. The general idea being that there are institutional silos that separate general nephrology, dialysis providers, and transplant centers, and how we might begin to dismantle those silos and start to work together and not just take care of individual subsets of patients with kidney disease, but create a system of care delivery and care coordination that would take care of people across the continuum of kidney disease, from chronic kidney disease to end-stage kidney disease to transplant and sometimes back again. That paper was variably received by the transplant community, but even the disagreements and controversy that it sparked resulted in additional debate and dialogue and ultimately meetings of the minds that weren't there before. And that was the trajectory that ultimately led Frank to offer me a position at Fresenius Medical Care. Fresenius Medical Care is a global dialysis provider that provides dialysis services and products to more than 30 countries. and to nearly 300,000 patients who require chronic dialysis, many of which are in the United States, but we serve some 20 countries in Europe, Middle East, and Africa, and another 10 or so countries in the Asia Pacific region.
Access to transplant medicine is obviously important to you, to your role. Talk a little bit about the IOTA rule, the Improving Organ Transplant Access, that you've delved into, and the importance of access for transplant, whether it's kidney or something else.
You know, the salient challenges in improving access to transplantation have changed a little bit over time. There's always been a disparity between the number of organs available for transplant and the number of patients who could potentially benefit from a kidney transplant. There's certainly more than one barrier. It's not simply a supply issue. There are also significant barriers sort of on the patient care level with regard to patients' resources, access to medications, and the like. So there is no simple solution to any of these challenges, but increasingly, regulators and the federal government have taken a deeper and deeper interest in doing what they can to improve access to kidney transplantation for more and more people. The rule you mentioned, the Improving Organ Transplant Access Rule, is a rule that was published by Medicare earlier this year. And it's an effort to try and incentivize transplant centers to significantly increase the volume of transplants that they do. There are a number of reasons why transplant centers have found it difficult to significantly increase the number of kidney transplants performed. Among the challenges are the fact that just as there is a shortage of general nephrologists, there's also a shortage of transplant nephrologists.
Sure.
So there's about 250,000, possibly a little more, patients in the United States who have a functioning kidney transplant. And there are about 800 American Society of Transplantation certified transplant nephrologists in practice. So the ability to care for newly transplanted recipients, as well as the thousands, now hundreds of thousands of patients who have a functioning kidney transplant, does put significant constraints on the system of care coordination and care delivery. There's also considerable efforts that have been undertaken to increase the number of organs procured from deceased donors and offered for transplant. Those efforts have certainly increased the total number of transplants a lot in recent years. But it also entails using kidneys from donors who have comorbid conditions that make them at higher risk for complications. Those complications need to be managed. It does make the care of patients who receive these organs more complex, which require more resources. But we're now seeing that the number of organs that are procured for the purposes of transplant, the utilization of those organs have actually gone down, and the rate of organ discard or non-utilization has gone up. So the IOTA rule is an effort to try and incentivize transplant programs to be more aggressive in the utilization of organs and be more risk tolerant in terms of accepting organs from higher risk donors. It's a first step, I think, but I think it will only durably succeed if these same policy efforts also take seriously the need of kidney transplant programs to be better resourced.
That's Dr. Benjamin Hippen. Dr. Hippen completed his fellowship in nephrology from the Heersink School of Medicine in 2004. Today, he's the global head of clinical affairs and chief medical officer for care delivery at Fresenius Medical Care in Charlotte, North Carolina. Dr. Hippen professes a profound understanding of UAB's medical history and has a great idea of what it means to be a Blazer.
I'm very proud to be part of an institution that had a storied history in this little corner of medicine that's made such an impressive difference for so many people. I am a student of the history of medicine and UAB has absolutely made its mark on the history of medicine. In thinking about getting ready for this podcast today, I found a picture that my wife took right around the time I graduated from my fellowship in front of a large bust of Tinsley Harrison, who's the author of Harrison's Internal Medicine, which for those who were not medical students or internists is these days probably a 3,500 page textbook of internal medicine that all of us either bought or said we bought in the course of our training. So I'm not comparing myself in the least, but to be a part of that tradition and to have attempted to make good use of the time and effort that people who dedicated their entire professional lives to training an entire generation of nephrologists is very special to me. And it's something that I think about a fair amount and also try and think of ways in which I can, in my own professional efforts, continue.
Be sure to check out past episodes of the UAB Green and Told podcast. Listen in at alumni.uab.edu/Green and Told. Have a story to share or know someone who does? Email greenandtold@uab.edu. Finally, be sure to follow us on social media. Just search UAB Alumni on Facebook, Instagram, and Twitter. Thanks for listening, and until next time, go Blazers.